I'm Dr. Deborah Higer. I'm a family physician in Mount Shasta, California. I trained at the Mayo Clinic for medical school, did my residency in Stockton, and I've been here just short of 20 years. In Mount Shasta, we are a very small rural community where we don't always have pediatric psychiatry available. And dealing with children on telemed is not always the most productive way to diagnose and treat children. So over the last 20 plus years, I have become the expert, so to speak, in pediatric psychiatry. I am not a pediatric psychiatrist. I don't do everything, but I have become a subspecialist in learning problems, reactive attachment disorder, ADHD, and things that are quite common like that. I started working with children with special needs when I was 16 in Detroit, Michigan at St. Francis Home for Boys, and I just found that it's my niche, and I've been doing it ever since. I've been doing this talk with Dr. Hughes now for probably 10 to 12 years, and so I'd like him to.
And my name is Robert Hughes, and I have been a psychologist since 2003 and a marriage and family therapist since 1996. And I have been working here at Ramy Vista Incorporated, a private nonprofit organization. We provide foster care and mental health services, and we provide a lot of other social support services for people in this community. My specialty has focused on the mental health needs of children in foster care, children who've been neglected and abused for my whole career. And it has been my pleasure to work with Dr. Higer through the years, just in collaborating with many of the different children that we work with here in Siskiyou County, and within her role as a doctor and mine as the therapist, and also within her role as an adoptive parent. And so she has been a great resource for us, so we really appreciate that. And we've been doing this talk for many years.
So we're hoping to get this talk out beyond Siskiyou County. So we have requested this video to be able to distribute it, hopefully at least nationwide, so people that have adopted children who have reactive attachment disorder, CPS, school teachers and school systems, the police, therapists, because dealing with children with reactive attachment disorder is very, very different than dealing with almost any other psychiatric disorder. And it looks very, very different. So we're hoping today to be able to go through the diagnosis, prevention, whenever possible, and treatment of RAD, and how the different people in a child's life might have different roles and ways to interact with this child that they might not necessarily innately do. I spoke with a therapist a few weeks ago who said, I need to not trust my instincts. Bingo. With RAD kids, you need to not trust your instincts because they're probably not going to help you in this situation.
There are many things. I have a PowerPoint, all of you have this, so I'll be referring to this. There are a lot of aspects of understanding attachment and how attachment affects children, and how disrupted attachments or the failure to have an attachment can result in problems later. And as Dr. Higer said, some of the things that we learn as therapists when we go to therapy school, so to speak, need to have this extra information, because some of the things that you learn, you have to specialize. You have to understand the specific issues resulting from an attachment disorder or trauma. And so that's what this is about, helping you understand the differences. Because a lot of the things that you will do for assessment, a lot of things that you might do as a therapist for individual therapy, a lot of things you might do as a rehabilitation specialist working with children, doing a behavior modification program, they won't seem like they're working, and then in many ways they won't work the way you might be used to having them work unless you understand and you can apply the principles that we're going to talk about today. So that's what we're about. So starting off with the basics, the diagnosis, the DSM-5 now. Things have changed a little bit. It's important to know, I also have other information for those who are interested from the National Trauma and Stress Network. and also from the Academy of Adolescent and Child Psychiatry that has come out with practice parameters. So those are available to you. And a lot of this, what I have, is from those two sources. The DSM. We have the DSM-5 now, and that has changed. It's no longer one diagnosis, really. It's been split into two. So you have the diagnosis of reactive attachment disorder. In the past, reactive attachment disorder was characterized by two different types of manifestations, right? You had the inhibited type, which was characterized by that kind of clinginess, more internalizing behaviors, more emotionally withdrawn, isolative, those kinds of things. Or you had the disinhibited type. Through research by Charles Zena and others, they determined that those were really best understood as two separate disorders. Not because their etiology is different. They have the same cause, which is maltreatment of children, neglect and abuse of children. But because they can require different types of treatment, and they hold together better just in terms of their manifestation as two different. One is called reactive attachment disorder, and that is referring to the inhibited type. And you can see it's basically the same as before with a few things. There is a consistent pattern of inhibited, emotionally withdrawn behavior toward adult caregivers, manifested by both of the following. The child rarely or minimally seeks comfort when distressed, and the child rarely or minimally responds to comfort when distressed. So they don't seek comfort, but even when they do seek comfort, it's very, very difficult to comfort them. It's characterized by persistent social and emotional disturbance, characterized by at least two of the following: minimal social and emotional responsiveness to others, limited positive affect, meaning they don't seem very happy, and episodes of unexplained irritability, sadness, or fearfulness that are evident even during non-threatening interactions with adult caregivers. Again, for this is the child that is super inhibited, not just shy. They are fearful of relationships with others. If you go on, then you can see the disinhibited social engagement disorder, and this is the other end of the spectrum, a pattern of behavior in which a child actively approaches and interacts with unfamiliar adults and exhibits at least two of the following: reduced or absent reticence in approaching and interacting with unfamiliar adults. Basically, they will just go up with anybody. You've seen this with children with foster care. They will approach anybody, a total stranger. They will seek comfort from a total stranger. If somebody said, let's go get a pizza, they'd go get a pizza. So they just don't have any of that differentiation. A lot of times, reactive attachment disorder is often diagnosed with other concurrent disorders, such as oppositional defiant disorder, conduct disorder, attention deficit disorder, and sometimes PTSD. The whole issue with PTSD is an interesting issue that we'll get into later. I don't know if you want to chime in on any of that nerdy stuff.
My kids were adopted. They were 21 months and just turned 3 years old when we got them. They had been in one foster home that was later closed for neglect. My kids are the two opposite ends of the spectrum. My kids are now 23 and almost 22. And we have been through a lot, because when we were little, or they were little, and we were struggling, very little was known about RAD. And getting the diagnosis to start with was challenging, and then there was a ton of trial and error, no matter how much we read, no matter how many authorities we spoke with, in just trying to figure out how to deal with these kids. My daughter was the disinhibited. She would walk off with any stranger, anytime. She had to be taught that carnies were not safe, and she couldn't just walk off with somebody. My son, just the opposite. He was incredibly clingy, incredibly bonded, but at the same time, trying to hold him or cuddle him or calm him, He would take off running from school. He would throw tantrums where he'd injure people. And we went through this process, and anytime he was away from me, it got worse. And so we went through this process where people were pointing fingers at me. You know, what are you doing to these children? Why aren't they behaving? Why don't they behave in school? And my daughter had a speech delay of almost 3 years by the time she started kindergarten. She spoke like a 2.5, 3-year-old. So people thought she was hiding things. So again, it made it a lot worse having no knowledge of the diagnosis, let alone the treatment.
So what causes this? What causes this kind of thing to happen, where children are not regulated behaviorally, emotionally, cognitively? Why would they be this way? Obviously, from the DSM, we can see it is because of severe and terrible maltreatment of children during their early childhood. You have a question?
I do have a question.
Yes.
What about kids who are, or babies who are born preemie and need to be in incubators for lengthy periods of time where they don't have consistent touch, consistent nurturance? I know that things are changing now, but I am kind of curious about how that is.
Well, reactive attachment disorder is the disruption of the bond between 9 months and 5 years. So 9 months and 5 years. The
As
child
well.
at around 9 months. Some I've seen as early as 8 months, and I've seen a couple of kids after 5. But it basically is the disruption of the bond with the primary caregiver. So the early NICU babies are usually home by 4 months, and there's more and more contact with them, and more NICUs are encouraging parents to room in, to spend time, to breastfeed, even the little tiny babies. So that they do get a lot of skin to skin now, and they're really realizing how important that is. Those kind of babies, unless they're meth babies and they were born prematurely and there's a poor bond to start with, don't really have an effect to the RAD other than the coexistence of why the baby was a preemie.
Okay, thank you.
That was a good question, because that's exactly the right idea to think about, is at what point, and as many of you know, those of you who have children, if you'll remember, those children during their infancy, up to 7 to 9 months, they're easily comforted they can be easily comforted by a stranger, pretty much. They have some preference to their mother and their father, and they will recognize their voice and all that. But they really are okay. You could leave them in the care of a stranger, and they don't show that fear response. They're okay. It's at 7 to 9 months. If you were to leave them with a stranger, now they start to have anxiety. That is a sign to us that they now have achieved an attachment. That's one sign. The idea, okay, the attachment has taken shape here. It's taken form, right at 7 to 9 months. So, yes, so that's what causes it, is a lack of attachment through some form of abuse. Most abuse reported in America, the latest statistic I saw was 63% of all reported cases of abuse are neglect. Neglect, failure to meet the child's basic needs for safety, for nurturance, for shelter, the basic biological needs. This is what causes it. Now, why would neglect be so damaging to a child at such a fundamental level? Why would they? Because we know from attachment theory, developmental theories, attachment theory, social learning theory, and now even understanding of basic neurology and some of the newest science in terms of the way the brain develops, that people are designed for relationship, that we grow, we discover ourselves within the context of relationship, and that starts off right at infancy. And so the whole idea of attachment theory is that the quality of the attachment in early infancy and childhood becomes for the child the internal working model for how all relationships work. But not just how relationships work, but what it means to be the self, and what it means to be in the world. And it informs all of that.
And many of these kids are in homes that are not stable to start out with. That's why they end up in the system. That's why they end up having the disruption of the bond. These are kids that are in some of the orphanages in Russia, in Kosovo, in places where they didn't have a strong bond to start with, they're then shipped to a different country, to a different language, to people they've never met, who are now raising a child who had a very disruptive first period of life. It's kids who are taken by the system, and they're taken by the system not because they're in a great home and we just feel like taking them. They're taken from the system because of the neglect, because of the abuse to start out with. So their home life was not a stable home life to start, which is why they were taken. Now we've taken them and put them with somebody else, so we've disrupted the very tenuous bond that they already had. Then, because of the way our system unfortunately works, they're in 4, 6, 9 foster homes in the next 1 to 2 years. So they have no ability to form a bond with the next person or the next person or the next person. And so the attachment disorder occurs. In my kids, Matthew was in the neonatal intensive care until he was 4 months. He was with his biologic parents for 4 months. And when he was taken, he was put into a foster home that did a daycare. And he had no clue that his sister, Celia, was even his sister at the time. She was left in the biologic home until she was 2. And again, the same parents who had no ability to care for either one of them. And the system tried everything they could to help teach these parents how to care for their kids. And they just couldn't learn how to do it, which is how they ended up in a year of foster care before they ended up with us.
So this initial attachment and bond is crucial for all aspects of psychological development. It's crucial for cognitive development, how we grow to learn and know things, how we know the world and ourselves. Emotional development, how we differentiate our own emotions and thereby learn how to regulate them. Because if our emotions aren't well differentiated for us, then we don't know how to regulate them. When we have an emotion, we're overwhelmed by that emotion and we can't regulate that. And it's also important for our interpersonal development. When an attachment is derailed, and like Dr. Higer said, there's the cause of no attachment, but there's also the idea of there is a limit to how many infants, how many people an infant can attach to. So that's why the large institutions, orphanages, where there's many, many caregivers can result in reactive attachment disorder, and a lot of serial disruptions to the attachment. Multiple foster care placements can result in a reactive attachment disorder.
So prevention would be to support our families early on when we know we have a high-risk family, when we know we have a family that may not have the strongest parenting skills, to get our family resource centers involved, to get the support so that this family has the best chance of keeping this child. Number 2 is when they have to be taken and put into foster care. If there's a relative who the child knows, keep them with somebody they know. The neighbor next door who's been best friends with the family for, since the baby was born is frequently a better choice than somebody they've never met. Try to limit the number of foster homes. So if you can get them into a foster home that will be able to keep them the entire time, and to encourage relationships between the foster parents and the bio parents if the child's going back. Any kind of connection like that would help a lot. So helping to prevent it by whenever possible. Sometimes it's not preventable. Your parents died in a car accident when you were 3. It's really hard to stop that from happening. And the weird thing is that 2 children from the same family who could be very close in age, one will get full-blown reactive attachment disorder, the other one, nothing at all. And trying to figure out, and some of the severity of the abuse and neglect that I've seen, and these kids are fine. And another child, you're going, that wasn't a whole lot of neglect, but they've got full-blown reactive attachment disorder, and the severity doesn't seem to be from what we judge as severe, but somehow the internal part of the child has to judge it as severe enough to cause this.
Yeah. Okay, so what are the kinds of things that happen as a result of the derailment of cognitive development? Shifting attention or agenda will be difficult. That's a cognitive ability that is difficult for children who don't have that attachment. Rigid and concrete thinking. I'm thinking of Matt on some of these.
Right, so a lot of the times, I'm gonna try to give you examples
Yeah.
of a little bit of kind of what Robert's talking
Yeah.
about. These are the kids who, it's time to leave, the park now. Most kids are, pretty unhappy with having to leave, but they'll go, all right. These are the kids that are on the ground throwing full-blown tantrums that you can't get off the ground. What we did with Matthew, as he got bigger, is we gave him multiple warnings. 15 minutes till we leave, 10 minutes till we leave, 5 minutes till we leave. And just that knowing that we had time, and it became a lot easier. So that was one of the things that did help, because any change, schools are a big things having to do with change. So they do pretty well the first couple weeks. We get a honeymoon period, then there's some problems. We can usually get those a little more stable, but during the time from just before Thanksgiving till the first of the year, when you have Thanksgiving and you have Christmas and you have parties, and all of the routines at school are out the window, these kids fall apart. They, again, the last 3 weeks of the school year, first 2 weeks of summer, very consistently, when the systems change, when their activities change, when it's not the same as it was the day before, these kids have a lot harder time adjusting.
More recent brain research by Bruce Perry and others has shown that there are really neurological effects of trauma early in childhood. For example, there is damage to the hippocampus. The hippocampus is that part of the brain that helps encode memories. Imagine as a teacher having the job of teaching a child a certain mathematical equation, and they don't have the ability to remember it that well. They have a hard time attending to the teacher's words, but two, to really encode that, so they have to over and over, and then you have the emotional aspect of feeling that they just aren't going to be able to do this. They have that emotional, they don't like the way they feel when confronted with these problems, because it makes them feel like failures or inadequate.
And these kids tend to, just on the whole, do better in reading, because reading's the same today as it was yesterday. Math is something new every day. I can't tell you how many times I felt like I was hitting my head against the wall trying to get Matt to do the math homework, to try to get him to do anything that was new from school.
Yeah. What about the emotional development that gets derailed? I'm on that page. They're not numbered, but the emotional derailment leads to difficulties with delaying gratification, self-soothing. That's a developmental achievement that you don't see in 2-year-olds, do you? Not as well. But as you grow, you're supposed to be able to learn that, okay, I have a desire. I'm going to want to delay that because of a better good or a higher good. But that's been derailed for those with reactive attachment.
So a lot of times saying, if you behave, I will get you an ice cream, in a half an hour, that's, again, a half an hour from now. It's not now. Mm-hmm. And being able to put something off even 5 or 10 minutes. With my daughter, her first grade teacher had a stamp and walked by her desk every 5 minutes. And if she was on task doing what she had been asked to do, she got a little stamp on her desk. And she had these stamps all day long. And if she got a certain number, the stamp in itself was a reward. But then she got something at the end of the day for having a certain number of stamps. And that was actually very effective for her in first grade, because it was every 5 minutes she was being rewarded.
And then, of course, there's the social derailment, where they don't know how to trust. They have a hard time. Imagine the person that is supposed to protect you is also the person that is causing you danger. It would be very difficult to have to change that, organizing principle deep within you, that your caregiver is someone you can trust. You can actually submit to them and know that they have your best interest at heart. Instead, you would want to be in control of that. You want to be in control of them. You want to be in control of yourself at all times, because that's what your heart says is the only way to survive.
And that's one of the cores on RAD. These are kids that are desperately trying to get control of the adults, of everybody in their life, and the last thing they want is control. So they're desperately trying to do whatever. They hoard food, they steal things, they hide things, anything to gain control, and at the same time, they don't want it. They're very good at pitting adults against each other. And that's one of the main keys in treatment, is there is no confidentiality in RAD. When you're dealing with the child, you are treating the entire family, you are treating the parents, you are treating the school, you're treating the soccer coach, so to speak. And every adult in this child's life has to communicate with every other adult in this child's life. When my son was in 5th grade, I adored this teacher because Matthew would do things like, well, Mom said, I didn't have to do that. Well, the teacher would immediately pick up the phone, and after about 3 times of that, and when he would come home, well, my teacher said, hello? It stopped within a month, because he knew that as soon as he said something that one of us went, we would talk to each other. And he suddenly became happy and calm because he felt like the adults in his life were in control. We had to do the same thing with his soccer coach. Thank God he was a good soccer player, and the same coach picked him 6 years in a row. So once the coach figured out how to deal with him, with me, Matt did great in soccer. He was an awesome goalie. But until we connected and all of the adults were together, Matt would just blow out.
It's one of those paradoxical things that you see in psychology a lot, where a person wants to be in control on the one hand, but then when they are in total control, they're very, very anxious. And so they also want to know that there is a higher power, so to speak. There is an authority that has them secure, has them held on to, because they want to know that they're safe and that they're secure. And so they really need that. And so they strive for control, and yet then if they actually get it, then it really causes a major problem.
And with this lack of control, what we try to do with these kids is prevent them from getting in trouble. So if you don't have to be the bad guy, and you can prevent them from being in trouble, like the kid who was lighting fires at school. He was stealing his dad's lighter. We locked up every single flame source in the house, in that kid's house. The kid that was bringing knives to school, Dad locked up every single sharp object in the bedroom with a key lock. We alarm these kids' bedrooms at night, so if they get up, we know. We have a young man that's been hoarding food, which my daughter also did. They're not eating it. My daughter got up at night enough to take enough food that we had to replace all the vent systems under our house, because she was just hiding the food in the vent. She never ate it. She was not hungry. She just hoarded food. So once we alarmed her bedroom at night and we knew when she got up, we were able to get up with her. Oh, do you need to eat? Come sit in the kitchen. Come eat. And then we'll take you back to bed. And so by preventing, my daughter didn't have a backpack for a long time because she was stealing things from the school or stealing things from the house. So by getting rid of the backpack and she just carried her stuff to school, the teacher and I both knew what was going back and forth, and we didn't have to worry about stealing because, didn't have a backpack to hide it in. So by doing preventive things like that, then these kids get in trouble less often, so they become, again, more secure, more relaxed, because they're not trying to find something to do to get in trouble.
I mean, I think that's a great example of what all foster parents can do, adoptive parents, therapists, and teachers, is to have an understanding of, for example, stealing or hoarding food, going out in the middle of the night and stealing. You'll hear, I've heard many, many foster parents really marvel at this. I feed them, they say. I feed them 3 square meals a day plus snacks they can eat whenever they want. Why would they hoard food? Why would they do this? And like Deb said, she didn't even eat the food. What was that about? Why do they do this? And you hear it time and time again from foster and adoptive parents. They keep doing this. Having an understanding of what's going on for that child from an attachment perspective enables the parent to say, okay, this is an anxiety-based behavior. This is a fear-based behavior. What do we need to do to help the child feel more secure? And so recognizing that, having an alarm on the door so that the parent can come in, not to say, you're bad, you're busted, you have all these consequences for stealing. No, so the parent can say, you're hungry, You want food? Come on in the kitchen. Let's put some structure around this. Let's put some routine to this. You can have food. And help the child in that way. Help the child soothe. So, go ahead.
Oh, and off on that one, a lot of times what ends up happening is the parent is responsible. The foster parent, the adoptive parent. It's your responsibility to make sure their homework gets done. It's your responsibility to make sure and so the parent ends up being the bad guy over and over and over. Therapists, teachers, schools, a big part of it is making the parent the good guy. The parent gets to do all the rewards. Therapists don't get to do rewards. Robert learned that one with my son. We went out and shot basketball. We're buddies now. That really blew things up at home. So homework, most kids should have an IEP. So if they don't do the homework at home and the school feels it's important, he can do it at recess tomorrow. But it's not my job. I will present the homework. I will offer to help him with it. But if he opts not to do it, making me the bad guy to force him to do the homework makes me the bad guy. In therapy, if the kid does well in therapy, the parent gets to reward it. If the kid does well in school, you had a great day at school, a note goes home or something goes home, so the parent gets to reward. The parent gets to be the good guy. They get to do the reward system. They get to, and again, the most important reward for any child is time with the parent. So 20 minutes one-on-one with that kiddo because they had a great day in school is the best reward that you can have. But we really want to emphasize communication, try to keep them from failing, try to keep them from having control, and let the parent be the one that gets to tell the kid how wonderful they're doing.
This, I think, requires a little, I want to spend a little time on this. And this is really important to me as a therapist who I've worked with many foster parents and many adoptive parents. And I'm convinced, I've heard the same story from people here in Siskiyou County, from people in Shasta County, all over the state of California. I hear the same stories from foster parents and adoptive parents. And the story goes something like this. I brought this child into my home to give them a secure place, a place where they can be loved, a place where they can be brought up. But I never felt like I could attach to this child. I never felt like there was a bond. I never felt like the child would just rest in my care. I always felt like the child felt like they had to be in control and be the boss. And then sometimes I felt like the child was punishing me as the parent because they felt that was their role. They needed to be in control. So the child started acting out in school. And I would get called in by the teacher and the principal, and I tried to explain to them what's going on in the home, and I didn't feel like they understood where I was coming from. I felt like they were looking at me as I was the problem, and I was trying. I took my child to a therapist, and the therapist met with my child individually, and they would meet with the child week after week, and the child would talk about how much they loved therapy, and the therapist would talk about how much they loved doing therapy, and yet this boy was not getting better. It was getting worse and worse. And after a while, I felt like the therapist started to think it was my problem, my fault, that I was the problem, that I was doing something wrong, because they were behaving fine during non-directive sand tray therapy, but at home, they would act. I couldn't believe what they would do. So much lying and cheating and stealing and temper tantrums, and it just seemed to get worse. When I tried to explain that to the therapist, again, I felt like the therapist just saw it as, well, what are you doing? Because the therapist seemed to have a good relationship with the child. But I could see that this was not a true attachment. So what's going on? Children with this attachment trauma seek out and find what I would call superficial attachments. They don't know how to, or do they feel dread in really resting into the care of an adult. But they do want attention. They do want relationship, so they learn to get it by achieving these kind of superficial attachments where they are charming. They know very well what the adults want from them, and they're really good at providing that. And they can be very charming, very sweet, very cute in a sense. they know how to behave, but once you put them in a place where now they're being asked to have a caregiver-child relationship, it's like Freud called this transference. This is that all of a sudden now that caregiver, that mom, is put in a mental category of caregiver, and there is great dread and anxiety in that relationship and only in that relationship. The mom will say, well, they blew up with her. They will blow up with her in ways they would never blow up with anybody else. Only with her. Why? Because she raised her eyebrows. She, who knows what the trigger was. But she is, in a sense, just by virtue of being in that parental role, she is putting a demand on that child that causes great anxiety and fear. You have a few stories about that.
Well, a couple things we did learn. One of the things that we started teaching Matt when he was about 11 is that we taught him that this means stop, this means leave. If he started to swell up, and a lot of times you could see it coming, and he would stop, he could go to his room, he could go outside, or he would leave and go for a walk and come back. And we're in an area that's safe. There was no consequences. And frequently, if I could get him to go for a walk, the first thing I would do was call his therapist to call him, because he would usually walk with a cell phone, and he would hear Robert when he couldn't hear me. And so I used other adults in our life to talk to him when I was the one he couldn't hear. And other kids with reactive attachment disorder, a lot of times if they're having that problem, their parents can get me to talk to them at those times, or their therapist to talk to them. And by allowing them to vent whatever it is, it could get calmed down a lot more quickly than some of the tantrums could happen. It's incredibly difficult. I used to teach a lot of parenting classes, and suddenly my kids aren't behaving. Having the school especially was probably the worst for me. Why can't you control your child? Why is your child doing this? Your child hurt the janitor. He's out for 4 days. And I had no clue, because what would normally work didn't work. But as we got things calmed down, as I had tools like getting him to stop and leave, I was no longer getting emotionally drawn in. And having his therapist available, not necessarily, because most of his tantrums were in the evening, but having Robert there to be able to talk to him at those times when it was getting bad, when it was exploding, I think we probably deferred at least half of it. And it taught Matthew how to deal with his emotions.
Maybe this would be a good time to just pause and see if you guys have any thoughts or questions as we're racing through this material. Any things coming up for you that you're wondering about?
Well, I was wondering, it did sound like it would be very complicated in the school context.
Mm-hmm.
And also a lot of the labeling and diagnosing that can happen within that context. So is there an assessment tool that you ran into with schools, or just as you were talking with the schools where there's a way you're able to help differentiate? Because I could see a lot of labeling happening, and then behavior modification responses that wouldn't necessarily help the core issue.
Yeah,
So,
good
yeah.
point, Jill.
With RAD, it's in California, it's considered emotionally disturbed. That would be the school diagnosis, and reactive attachment disorder would be the medical diagnosis.
Okay.
So I have to pair my diagnosis with theirs. With the emotionally disturbed diagnosis, most of these kids have a 504. Almost all of them go as high as having an IEP, or an individual education plan. So you have a lot of leeway in being able to structure their day.
It's a difficult question, your question about labeling and diagnosis. In my research, of all the current people who specialize in working with attachment disorder, there's pretty clear agreement that our current nosological system, our current diagnostic classification system, is not adequate. It doesn't quite capture what we're seeing. So what does that mean? That means, like as Dr. Higer said, the schools have their classification systems, emotionally disturbed, learning disabled, whatever those are, and then we have our clinical diagnoses. Now, not all children who have oppositional defiant disorder have also had this attachment trauma. Not all children with ADHD have had an attachment trauma. Not all children with conduct disorder have had an attachment trauma. But those who have had attachment trauma may have symptoms consistent with ADHD, oppositional defiant disorder, and conduct disorder. So you just have to know what you're dealing with, and the key thing is to do an accurate history to understand, has this child been have experienced severe maltreatment earlier in their childhood? Has this child been abused or neglected? Or have they experienced multiple caregivers or experienced multiple transitions? That's your first and most important clue. Charles Zena and their research in the practice parameters, then they would say, for those of you who are therapists, when you're looking at making a diagnosis, you would also want to do observations of the child with the caregiver. Because really this is a relationally based disorder. This is not a disorder. The thing about the DSM from the medical model is that it kind of assumes that the disorder belongs to an individual. It's in them somehow, right? You have this disorder. You have reactive attachment disorder. But that's really not what we know to be true about many psychological disorders. And this is very much about that. This is something that we should be looking at in terms of the relationship, the quality of the relationship. It doesn't just belong to the child. It is seen as a relational thing. And that's why also the treatment needs to be a relationally based treatment. That's where I kind of had to learn the hard way, which is to recognize that my most effective treatment, which we'll talk about a little bit later, the most effective treatment was my working with the parent, developing a supportive relationship with the parent. And in a sense, I'm working through the caregiver to affect the child. Any other method has great risks, and we'll go into that.
Let me one more comment on that. One of the hardest things that I found early on is reactive attachment disorder was not well known. I even called back to one of my best friends at Mayo in medical school, who's a child psychiatrist. And when my kids were 7 and 6, she had no idea what the diagnosis was. And the schools trying to explain to them what this is, and that, because, oh my God, this kid's doing this, we need to call CPS, we're sure that it's abuse. Because this kid will tell stories of, oh yeah, last night they locked me in my bedroom, and then they beat me, and then they, and so CPS is called, and which only makes the situation worse because the child's now gained control. Once my kids had a lawyer, I knew they couldn't activate the system because these kids know how to play the game. And it didn't cost me much just to have the lawyer send out one letter and be there in case. But that was probably one of the biggest things we did in turning stuff around, is stopping the system. The number of kids that we've dealt with, we had a very controversial court case where we had these 2 kids with reactive attachment disorder in a local school, and every time they called the parents, the kids became instant angels and became better. Well, these kids were trying to get home. They were trying to get to their parents. So as soon as the parents showed up, suddenly the kid's like, I'm happy, I'm going home now. So they would have behaviors in school to get suspended because what they were looking for was to go back with the parent. Well, as soon as we started doing in-house suspension, if you screw up and you have those kind of behaviors, you're not going home with mom. You're going to stay here and be detained after school for an extra 20 minutes, and you lose recess. Wait a minute, I'm not getting what I want out of this. And again, the behaviors, stop markedly, but a lot of it's trying to educate the principal, the teachers, the janitor, whoever works with these children at school, what it is you're looking at, because again, it's treated so differently. We recently had a kid that I referred to Ramey that had been referred, and when they looked at what the kid's problems were, they're like, oh no, this is way too complicated. This needs to go to behavioral health. This kid's at moderate risk. Well, as soon as I put a reactive attachment disorder and you looked at their behaviors in that light, they're like, oh, we can handle this. This is just reactive attachment disorder. Those behaviors are there because of reactive attachment disorder. This kid really isn't oppositional defiant. He's really not trying to injure his baby sister. He's just trying, to gain control. And so by doing this kind of education, which is primarily why we're wanting to do this video, is so that we can educate the schools. So if a parent is having a problem, they can hand this to the principal and say, do you mind looking at this? This is my kid. The therapist. CPS, the court system. And so that's a lot of why we're doing this in the first place.
Do you have a question?
Yeah, I think it's really, I'm glad you're emphasizing the communication with the school, because I think that's a really vital piece. And I'm working pretty much exclusively with preschool age children right now, so that's 3, 4, and 5. And I'm wondering, what's the youngest RAD client you've ever? How early would it show
I've
up?
seen
Well, it'll show up. It
I've
can
seen
show
it
up
in
at
2-year-olds.
Yeah, you can
At 2,
show
okay.
up at 2.
Okay.
And how early do you start therapy?
You can start therapy at 2, believe it or not.
And again, the therapy is not child-centered therapy.
That's right.
It is parent-centered therapy.
That's
And
right.
what if a child's in foster care and not with parent and probably won't go back home with the parent?
Robert's gonna love this answer, so I'm gonna let him talk about transferring attachment.
Okay. Well, yes, you can do that. So attachment can be shared, a limited basis, and an attachment can be transferred. That's why we do want to help foster parents develop a strong attachment, even if the child is being reunified. And it might help the biological family to understand, because that can be tough. How do I work? How do I, as a biological parent, feel okay about my child developing such a strong attachment? And what about when they do reunify? Aren't we going to hurt the child? Aren't we ripping the child away from an attachment? And isn't that going to harm the child? Those are good, big questions that we struggle with. The answer is no. That the foster parent must help form a strong attachment, and that facilitates the child's subsequent attachment with the biological parent. If the foster parent does not formulate a strong attachment, it's not just interfering with that one relationship, it's interfering with the whole child's attachment ability. And so it's very important, and sometimes it might help biological parents to understand that by forming this attachment between the foster child and the parent and the child, it's facilitating the attachment. Then when there is reunification, that attachment can be transferred. The younger the child, the more important it is that be a partnership between the foster parent and the biological parent. If there is active hostility between two caregivers, then the child cannot share attachment between two caregivers who are in active hostility towards each other. Then we see that in cases of divorce. When there is active hostility, then that's very, very difficult for that child to share that attachment. So it's crucial that we help the biological families and the foster families learn the importance of each other in the child's life and cooperate. They don't have to agree on all their values and every aspect of child rearing. But especially with the younger child, the earlier the child, the more they can agree on day-to-day routines, like bedtime, lunchtime, meal times, bath time, bedtime routines, all those things, that kind of rhythm of life agreement, and also rules on behavior. We want to minimize. You're going to have two different styles of parenting, there's no doubt, but if you can minimize the differences in terms of, well, this behavior is okay in this environment, but it's not okay in this environment, those are not just confusing. Those are interfering with the transition and the transfer of the attachment. And so that's what we want. Did that answer your question? You said how early?
Yeah, I'm actually, it's related to a specific case that I'm.
If, like Dr. Higer said.
The mom is no longer going to be involved, and
If the
so then
mother's-
do you do therapy with the foster
Yes,
parent?
absolutely.
Absolutely.
And you would do a parent-child therapy, like parent-child interaction therapy. See, PCIT is an excellent evidence-based practice because it is absolutely between the parent and the child. The therapist's role is as a live coach, and they're not even in the room. They are speaking to the parent with a receiver in the ear. So it is a perfect form for children who are ages 2 to 7 years old. I would highly recommend PCIT as one form of live coaching. Yes.
Robert, I'm curious about situations where the child is either pre-adolescent or adolescent at the point that we get to the intervention stage. So we're looking at those type of behaviors that, ODD or something like that, you would be looking at those diagnoses as possibilities. So since there's already the differentiation happening in the normal development, how do you address that with the caregiver? And so if you were coming into that situation kind of there, and this might be
No, that's
down
a
the
good
road,
question. That's a
but-
very good question. Because you're saying during adolescence, there's a developmental challenge right there. They're under developmental stress as they try to differentiate as adults
Right.
now.
And that whole idea of control.
And that whole idea of control and, hey, you can't tell me what to do, and those kinds of things. And in some ways that can look appropriate from an adolescent developmental perspective, but what is required for healthy development and differentiation at that stage requires still a sense of secure base. So if the base is not felt as secure, then those kind of rebellious behaviors, those kinds of pushing away behaviors are going to be more radical and more all over the map. At that stage, a child with reactive attachment disorder is at high risk, if they're female, especially for promiscuity and indiscriminate attachments with boys. For the boys, it is much more, there's a high risk for juvenile delinquent type behaviors, crimes, those kinds of things. Some of those superficial relationships, also drug and alcohol abuse is a very high risk, because it's one of the few times when they are with their peers, if they're all drunk, they can feel like they kind of fit in. They can always excuse any kind of weird behavior by saying, I was so wasted, how did I act, and was I stupid, that kind of a thing.
You also got to realize these kids emotionally are 3 to 4 years below their genetic or biologic age. So a 13-year-old is emotionally 9, 10, just on average. They tend to have poor social skills, and they will allow, my son explained to me, he just got a promotion at the ski park, so he now supervises other kids on a chairlift. And he came home and he said, Mom, I hate this. I don't want to be in charge. I don't like being in charge. I don't want other people to look to me. I want to follow somebody else. I want someone else to be the leader. So they're going to be much more likely to follow whoever it is that will take them in. Also, a lot of these kids have reactive attachment disorder because they were taken, because they genetically have a predisposition to drugs and alcohol. So their parents were meth addicts, their parents were alcoholics, so by the time they get to be teenagers, they're genetically predisposed already, and then you put them in a situation where if you stuck a 9-year-old with a 13-year-old just in general, the 13-year-old's going to be in charge. They're going to do whatever they said. And the kids at school that are doing well and high academic aren't going to hang out with the kid necessarily who's a little squirrely and who's only 9 years old when you're 13. So it's a lot of situational things. And a lot of the time, I don't like to use other diagnoses. If I have RAD as my diagnosis, I'm happy to have ADHD in there because you can kind of sort of treat part of that. But when I've got an RAD diagnosis, I leave alone oppositional defiant. I leave alone all of those diagnoses because I really believe that it's a component of the RAD. And if we're treating the RAD, then the thing that looked like oppositional defiant gets treated.
Sandy?
Yeah, I just want to comment that I've been studying child development now for 3 years, and it's hugely illuminating, not just for little children, but for understanding the behavior of older people, including myself. And I don't think it's attachment generally, much less RAD, is given nearly the attention. I was shocked at how, it's kind of just thrown in there in developmental courses as just, okay, there's Vygotsky, there's Piaget, and there's attachment theory, but
Right.
no depth to it, and I think
Yeah.
that would really help.
I always tell, when I teach child development at Simpson University, I will go through all the different theories of development, and there are. Boy, your textbook for child development was this thick, and there's tons of theories. But I always do point out that when I look at evidence-based practices, those practices for children that have proven to be effective, like PCIT or trauma-focused cognitive behavioral therapy, those are almost always based in part on attachment theory and social learning theory. Those two developmental theories are crucial. I want to, did you want to say something?
Well, I just wanted to, because I want to make sure that other family physicians who are in areas that don't have psychiatrists or pediatric psychiatrists ready available, that this is something that can be done in your office. When I meet a family for the first time in this county, almost all of our RAD diagnoses are made by myself or Dr. Hughes. And when we started doing this probably 12 to 15 years ago, anytime one of us thought we had a kid with RAD, we'd call the other one to confirm it. Now I think we both feel comfortable doing that. But when I'm meeting a kid, usually referred by the school, by another doctor, a family just brings them in, somehow they get into my office. Behavioral health, our regional center will refer to me. And the parents, I just don't understand. My kid, yada yada, started fires at school. They started 4 different fires in 3 days. So when there's this weird behavior that's not typical of most kids, especially young kids, and you get a history of some sort of a major disruption in that bond between 9 months and 5 years, I put RAD on the table until I rule it out.
So, I wanted to, on your PowerPoint, we've skipped over a lot, but I wanted to direct your attention to the assessment page where there you have a little table here. And this is just something for you. I got this out of the Charles, Dina, and Boris. They're what do you call it, the practice parameters. And it's a helpful, so if you are observing a parent and a child interact, you can look at these different sections, like one says affection and adaptive for a young child. This would be for a young child, showing affection across a range of interactions. Maladaptive is lack of affection or promiscuous indiscriminate affection. Seeking comfort. Adaptive is seeking comfort from a discriminated caregiving adult. Not discriminating as in, racially discriminative, but, discriminated means the individuated. Maladaptive, lack of seeking comfort when hurt, ill, or frightened, or comfort seeking in an odd or ambivalent manner. So I'll let you guys can just read through those, but these are just ways that when you look and you're considering, does this person possibly have RAD? These are ways to check that out.
One cool hint is if the child is more strongly attached to the therapist after 2 sessions than the parent, think RAD. You had a question.
Yes, I'm wondering, as a therapist who's in the school setting as well, if you could maybe hit a couple of points that you have found when you do sit in an IEP, how you've been able to influence restructuring a child's day to make them more successful.
The number one key with the school, or the number one things we've done, one is communication. You've got to get the parent, the principal, and the teacher on the same page. The child, in front of the child, they have to know that as soon as the kid said, my mom said, the teacher goes, gee, Deb, did you say? Kind of a thing, that they can't in any way pit any adult against any adult, and if they find one, they're going to use it. You may have to talk to the cafeteria people if that's where your kid's hanging out, or the librarian. Next is finding the teachers that are the most structured and the most caring. My son, with his 5th grade teacher, he had to hug her every morning when he got to school and before he left every day. And my son was an avid reader. And so they would read the same books, and he would get to school 10 minutes early just to talk about the books he was reading with this teacher. And that really formed the bond with them. Things that they're in trouble for at school, stay at school. Okay. If your kid gets suspended, it's an in-house suspension. They don't get to go home. They are suspended in school and they stay in school. Rewarding. With my daughter, actually both my kids, when they were doing what we wanted them to do in school, they were allowed to call home every hour. Just for 5 minutes, but they could touch base with me, I'm doing really good in school today, I just wanted to tell you that. And they get very secure by hearing their parents' voice, and that really strengthens the bond. Having them involved with other kids in structured environments. My son is very intuitive, and they actually used him in junior high. When another kid was upset, if he was somewhere around, they would bring Matt into the office to talk the other kid down. Because Matt could do that. So even though he wasn't the most popular kid, and he never was, but they found a niche for him. They found ways to reward him for doing well kind of a thing in the places that work for him. At one point, there were some kids picking on him, and the principal actually told the kids, if you come within 15 feet of Matthew, we will suspend you. And they actually set up a boundary within the school, whatever what activity was, and they couldn't go near him. And it worked great. So they protected him. And again, that was also very helpful. So those are the kinds of things. And the thing that we found worked the least is I had a teacher at one point, he was a special ed teacher, who undermined me. Matthew did terrible with sugar and with video games and videos. And this teacher would give him candy after school and let him watch videos because I was mean and wouldn't let him have that at home. Matt also had an ADHD diagnosis. He was allowed his sugar and videos on Saturday afternoon because it didn't affect his school day. He didn't come home and blow up. But when the teacher undermined me, Matthew just lost it. He probably regressed 6 to 12 months in about a 2 or 3 month period because the teacher and I were not on the same page. And it made it very, very difficult. Does that give you some help on that?
Very helpful, thank you.
And that happens so often. That's why one of the things that we're so, I really want to get the message across is that the treatment is with the parent, never against the parent, never outside of that parent. I undermined Deb a number of times, just by mistake. It was so easy to do. I mean, it wasn't like I thought to myself as a therapist, you know what, I'm going to really try to undermine this parent today. No, I never thought that. But when I promised to, keep a secret.
Yes, don't tell mom is pick up the phone and call mom now. The same with two parents. When I was in a relationship with someone, don't tell mom, and Matt would hate it that I didn't know something, and his behavior would just blow up because mom doesn't know that I have a knife. It's only a little knife. I found it outside the library, but I have a knife. And
if my mom finds out, I'll be in terrible, terrible trouble. And so the therapist says, well, okay, you and me, I'm your buddy. I'm safe. I won't say anything to your mom about the knife so you don't get in trouble. Okay, boom. You wouldn't believe how bad of a week he had that week. I mean, it was just crazy. Not because I undermined Deb. It was because he knew that he was getting away with something, and he caused too much anxiety for him. It was really, really tough, and he had successfully split us by doing that.
So Matthew, for his 18th birthday, because Matthew had a fixation with knives, and Matthew had finally, when he graduated high school and was 18, one of the things I bought him for his 18th birthday was a little pocket knife with about a 4-inch blade, because by that point I trusted him to have a knife in the house. At 14 or 15, not a chance in the world would I have trusted him. If he got into one of his anger or rages, I don't know what he would do with that knife. So it was a huge rite of passage for him to have mom give him that for his birthday when he turned 18. I don't think I could have bought him anything more important to him.
That was huge.
So things like that, and it's amazing, but there is no confidentiality, not between therapist and child, not between teacher, not between coach, not between anybody. Every adult in this child's life, and even now Matthew still calls Dr. Hughes, and I still know what they talk about. Not specifics, I don't need to know that, but if Matt's doing something crazy, I'll call Robert and say, you may want to talk to Matt. He's struggling this week. And we found out that that's worked really well overall, because Matt, a lot of times, he's getting better. He'll actually call Robert and say, I think I just need to talk. But sometimes, I'll still pick it up. And one of the oddest things is Matt, who's now almost 22, if something really good happens with Matt, I'm his first call. Not his friends, not anybody else. I'm the person he needs to tell about it first. And that's really cool that our attachment has gotten to a point where I am that important in his life. And that he feels secure in that attachment.
It's not easy for therapists. This is really kind of it takes a lot of wisdom and judgment. You can't just, obviously there is some privacy to the therapy situation. Otherwise, you know, if, for example, Matt, he wouldn't call me. It wouldn't be easy to talk to me if he thought he was just talking to his mom through me. I mean, obviously there's going to be some privacy. But any time there was any hint of him blaming her or putting responsibility on her or trying to get away with something, he had to know that I wasn't going to buy into that she and I were a team, and that I was supporting her relationship with him.
And how would he know that? Like in the session, how would you respond to him in real time?
Well, first it's important to know that what I did, and this is what I recommend, and in fact this is what the research tells us, is that any time I met with him individually, it was only as an adjunct to working with Deb. My whole thing, not just Deb, I'm referring to her, but with the parent, whoever the foster parent is or the adoptive parent, my approach, and the approach that research tells us, is that it is through the caregiver, number one. That's what you want to do. Like PCIT is a great example of it. But for the older kids, parent education, parent support. They need to finally have a therapist, another person who they can tell their story to and feel like, wow, this person understands and is listening to me and is here to support me. In some of the handouts you could see, I give some ideas about that. Giving them the empathy, understanding, giving them unconditional positive regard, all the good Rogerian things for them. Sometimes they require some advocacy. They need some voice with the schools or with law enforcement or with CPS social worker, just to be able to say, no, they have a valid position here. They're seeing something real, and I'm hearing them. I'm on their side, so to speak.
And you know, like the little kids, the PCIT stuff, things that are structured that are 100%, you know, involving the parent, is great. As the kid gets a little older, you know, it may be a half hour as a family and then a half hour individually. So again, and minimal sand tray, no going out and shooting baskets. Sorry, dude. No just hanging out with the kid and having a good time. Planting flowers outside of the office with the kiddo. Those are things not to do in therapy with these kids, because suddenly you are the one rewarding them and not the parent.
Well, what I found too as a therapist wasn't just that the reward or not reward part. It was the fact that when I did not have it more structured, and in fact it was so much better when the parent was in the room. So the second one, if you're not doing just totally working with the caregiver, is you're doing conjoint therapy with the caregiver and the child in the room. Because I found that I didn't get the true self of the child unless the parent was in the room. That when the child was just with me alone, I couldn't break through that defense. I couldn't break through the charm. I couldn't break through the happy, everything's happy. Everything was fine. I couldn't get through there. I had to have the parent in the room to really get at the emotional and I help them identify those emotions. Then when I do see them individually, it would be as an adjunct to that. In other words, I might be doing some cognitive behavioral therapy to help them change some of the ways they're thinking about relationships or how to communicate or how to resolve problems. So in those cases, now that I've set it up, the whole treatment is set up where there is a very clear unity, not just between me and the parent, but me, the parent, and the teacher. It's the holy triad. That's really important. Those three, we're very, very closely communicating. Then if, let's say, the client says, I've got a knife in my pocket and I hope you don't tell my mom because she'll kill me. My response in that case, after having already set this up, is, well, you know, as we've talked about before, what you and I talk about, I don't have to share everything. But when there is an issue where you have violated the plan, or there's something that's unsafe here, you know, I'm going to share this with your parent, because your parent, your caregiver, your foster parent cares about you, and they need to know so that they can care for you. Now, my promise to the child is I'm never going to just go around your back. I'm never going to talk to them like sneak around and say, no, everything you say is confidential, and then go around your back and tell. No, I'm going to be open and honest. So my promise, and most of them can accept this. In fact, they feel the holding environment in this. They feel secure to say, okay, I'll say, no, this is something we need to talk to your mom about. Would you like me to bring her in and you can tell her with us here in the session where I can be present? Would you like me to call her right now while you're standing here so that you can hear? Let's do that. Anything that we can bring them all together, and then I will communicate that.
I'm just fascinated with this whole boundary setting dynamic, because it's a truism that kids, act like they want to be in charge, but they really want the parent.
Mm-hmm.
It is very hard. I've noticed it's very hard for parents to get that.
Mm-hmm.
They worry that, I'm not his friend anymore or something like that.
Yeah.
So I'm wondering if you can, if it's appropriate, if you can go into any kind of, if there's any way you can think of to explain that makes sense to parents
Well,
who are in that dilemma.
it is a tough one. I mean, go ahead.
Well,
You can.
basically, a lot of parents think they want their kids to like them and they
Right.
want to be their child's friend. And I tell parents from the very beginning, number one, they have friends. You're not it. Number two, you're the parent. You're in charge. You need to set limits. And it's amazing. Robert talks a lot about the best parent is the one that has really good structure and
Right.
really high warmth.
Right.
That's your best environment. So being the parent and telling your kid, okay, it's bedtime at this time, this is where we're gonna eat, you don't get all the sugar you want in the world, this kind of a thing. And if you take that and put along with it a lot of high warmth, 20 minutes every day, it's just you and me. And we're gonna spend that time doing something we both really like doing. So teaching the parent to parent, and that's what I do a lot of in my office.
Yeah.
I frequently will say that 90% of parents really want to be good parents, but just may not know how, and
Right.
teaching them how to parent is great. And 10% never should have had children. And they're never going to learn. But it's amazing how many parents I've had in my office who will look at me and go, you want me to play with my child? What exactly does that mean? And so a lot of it's teaching real basics. I use the parenting classes here in town a lot. Really refer them. We've got some really excellent parenting classes where parents really learn how to reward your child, how to structure your child. And kids with a lot of high structure are much, much happier than kids whose parents go, oh, let me just give you everything you want because, I didn't get that as a child.
Yeah. Well, I'm totally on board with everything you're saying. I guess what real question is,
How do you communicate this to parents so that they
so they really get
They
that
get this.
the presentation of the child as defiant and angry and all that actually conceals a desire for more structure.
Yeah. I mean, the way you just said it is really excellent. Sometimes I'll even draw this picture. We know from Diana Baumrein, her longitudinal study
Yeah.
on parenting, and there was authoritative, which is high warmth and high structure. There's permissive, which was high warmth and low structure, and there's authoritarian, low warmth, high structure. And which one of those had the worst outcomes for children? For juvenile delinquency later in
Permissive.
permissive. That's correct. High warmth, but low structure. By far had the worst outcomes. Not by a little bit, by far, in terms of juvenile delinquency later. So the structure is very important. But here's the key about warmth. See, authoritarian's not good either. And the problem with authoritarian is you need to have your structure go up here if your warmth is only down here. Why is that? Because it's the warmth that fuels the structure. And one way to put that is if you have, for example, you have a disciplinary technique you use called timeout, which we teach, right? We teach people how to do timeouts as a form of discipline. It's an excellent form of discipline. But timeout will have no effectiveness unless time in is reinforcing. If time in is a bummer, then time out is a holiday.
Yeah.
And so the warmth matters, and especially with RAD, these both matter. This is where it's hard. This is why parents need so much of our support and help, and everything we can give them, because they've got a hard job. Those of us who've been parents, this is hard to maintain high levels of both.
when I got Matthew at 21 months, he was diagnosed with autism. He was never supposed to speak. If you picked him up, he'd stiffen and scream. He was already in a special baby school. The first night I met Matt, officially, I'd seen him in my practice once or twice, but the first night we met him, he had just learned to walk at 21 months, and he didn't speak at all. He didn't babble, he didn't make any noise, he played with cars silently. He would double fist feed himself till he threw up, and he wasn't even on the growth curve yet. He was teeny tiny. The social worker brought him into the room with Celia, and they didn't know they were siblings. They were in a foster home together, but there were so many kids, they didn't know they were related. Well, they came in the room, we were across a very large room, and I looked over, I said, "Matt, how you doing, Matt?" And he looked up, and his eyes lit up, and he ran over and he threw his arms around my neck, and that was it. I was in love with this child, who was in love with me, and the social workers all went, because this child had never shown any affection to anybody. Nobody could touch him, literally. You could put him in a car, you could put him in a crib, but that's it. You could not in any way. And so that was the start of our process. So that was Matt, and he was so afraid of losing that connection as much as Celia was going to keep me at arm's length to make sure that she never got hurt by that connection again. So that's how they were so different. In the same kind of environment, they came out opposites.
Well, I think some of the parents I'm referring to, I've noticed, my suspicion is they have attachment issues themselves.
That
They
might
have
be true.
not
That's
had
right.
help to work through.
That's a very, very true. And you know, we think about the child all the time in terms of attachment, but we don't often think about what happens in a parent's heart with a child. Like that description from Dr. Higer, what must that have been like? She fell in love with him, is the way she put it.
Yeah.
That's powerful. And so these parents need, this is why I'm so strong on supporting these parents, the foster parents and the adoptive parents, because imagine the pain, the guilt, the shame, the feeling they have of inadequacy when they can't get this child to bond with them. And they're having feelings they don't even understand why they're having. Why are they having these feelings? And they need so much of our help. One of the things they need is to learn how to process those emotions and even being able to regulate their own emotions in the heat of the moment. Because one of the things you don't want to do is inadvertently validate the child's inner experience of being unwanted and rejectable and all this by your losing control, of your own emotions. And so being there for the parent, but too often the parent is felt they're totally on their own. They're completely isolated, and they don't have anybody and they can't ever admit that they themselves have problems because they're worried that the therapist is going to report them to CPS, or CPS is going to come and take the kids, or the social worker is going to move them because, they don't feel as good in this foster home, so let's put them in this foster home. And we have these things used to, and still do too often, happen all the time. People are getting moved because, this is just not a good match. And what we're really missing is how do we really support these caregivers so that they don't get overwhelmed. They're often just overwhelmed, heartbroken, and overwhelmed.
And one of the hardest things for me was I was already working with kids with special needs at this point. I could help everybody else's kid but my own. And I'm being pointed fingers at by everybody on why can't I make my child behave. And it wasn't little behaviors. Even at 5, Matthew took off on the nanny that I had at the house in the afternoon to try to get back to my office, and ran a half a mile or a mile away, ran off to the railroad tracks, places that were unsafe. Just bizarre behaviors. And it took a long time to realize and to get myself feeling again like, I really am a good parent. And I really do know how to parent. I really do know how to teach parenting. And having the support of all of those things, because there is no perfect parent. Going back, I go, God, I wish I could have done this one different. I wish I could have, and I don't know if it would have changed the outcome at all, but looking at my kids now as adults, they're amazing. They're both really amazing people. And no matter how hard it was or what we went through, it was worth everything because that's who they are now.
Yeah.
So let's I'm not going to have a whole lot of time. I'm betting they're going to cut us short.
very shortly.
Okay,
So-
there's one last thing I wanted to present, that's
Yeah.
called the coerced validation process. I think I've talked about this before. But this will help people understand why is it that with a certain child, you give them praise, you say, thank you for sitting still in your chair, and that provokes them to jump out of their chair and misbehave. Why is that? Why is it that you try, you'll hear parents say, I tried to praise them. I tried to give them rewards, and it backfired. It doesn't work, they say. This doesn't work. Praise doesn't work. And you have to help them understand. One of the reasons is this idea of coerced validation. In other words, a child, any human being, in order to be differentiated, in order for us to know ourselves and know our own feelings, we need to have an other who will see us, who will acknowledge us, who will repeat back to us mirror back to us who we are, and accept us or validate us. But there are times, especially with children who've been neglected, there's aspects of their whole self-experience that has been left unacknowledged, unvalidated. There's been no reflecting going on from the parent, no mirroring. And so they have this inner experience of, I'm abusable, I'm damaged goods, I'm bad. And when you treat them as a new caregiver, if you treat them and you say, you are good, you have value to me, that is a counter message to their inner experience. And that causes anxiety. Oh, wait a minute. Either she doesn't really know me, or she doesn't really want to know me. And I'm going to get her to see the real me. I'm going to behave in a way that's going to get that look of what I need from her. I need her to mirror for me the inner experience of, I am rejectable, I am bad, that mirroring. And so there's this acting out. There are many different ways that people do this, including, for example, cutting. Now, this is not necessarily a RAD thing, but it is a way of getting the environment in a sense of, to provoke somebody in the environment to give me a response that validates an inner experience. The problem with this is that kind of validation is not a true validation. It is false. It's validating a falsehood about who I am. Because as a human being, I am a person of value. But I am thinking I'm not, and I'm getting that. And so it becomes addictive, because in the moment it feels like it meets my needs to feel consolidated and whole. That's right. Person who cuts themselves goes, that's right, because I am damaged goods. I am bad. Or if I get you to respond to me, yes. And anything that feels like it meets your need in the moment, but it doesn't really meet your need, is addictive, because you have to do it again and again, but more and more and more, just like any addictive thing. And so one of the things we can do to help caregivers is to help them learn how to recognize when this is happening and not validate that, not go there, be very businesslike, very much like Dr. Higer said, just hand up, that means stop. Finger out, that means go for a walk. We're not going to engage in this sort of shouting match or this sort of meltdown, which is really, even though it's painful for the child, is nonetheless reinforcing the whole behavior and the whole problem. Why? Because there's some things that are deeper than pain and pleasure. And attachment is one of those things. Attachment, and because that has to do with meaning, human meaning, and that's deeper. That's why a lot of the behavioral principles, if you're using behavioral principles, that's great, but if you're doing it without a proper understanding of attachment, you're going to get frustrated. Behavioral principles work for everybody, including pigeons, right? We know that. Mm-hmm. But you have to understand the attachment side of that, or else you're going to miss one of the most reinforcing experiences, which is that that mirroring and that validating.